Dysrhythmias, we're looking at now the ventricles, right? So when we look at ventricular arrhythmia, okay, we're thinking about which part of the PQRST? Ventricular arrhythmia, the QRS, yes. Okay, so the first one we're going to look at is premature ventricular contractions. And if you remember, we had premature atrial contractions, right? And so these contractions, the ventricles contract too soon. So remember we said if it's a P problem, we're going to see, usually we're going to see the P's, but when it's a ventricular problem, we're not going to see the P's, right? But in this one, because it's only one signal that's off, we're going to see normalcy in these, but in here, like I said, we don't see a P, right? So we'll see it here in the normal ones, but the one that's causing the problem, we're not going to see a P, right? So this is the ventricles that contracted too soon, normal beat, ventricles contracted too soon, okay? So a premature ventricular contraction is an atopic impulse that may occur in healthy people without causing problems, okay? The PVCs may occur single, this is a single one, or they can occur in twos or threes. If there are two, they're called trigeminy. If there are two, they're called bigeminy, and if they're three, they're called trigeminy. Okay, so what that means is if there were two of these, there would be one here and one that looks just like it right next to it, then a normal one. Or if there were three, it'll be 1, 2, 3, and then it will go back to normal. And there's a big problem with the bigeminy, trigeminy, or what we call the run, is that eventually, if they continue, they can cause VTAC. Because you'll see VTAC looks just like this, right? But all of it looks like that, okay? So when we look at premature ventricular contractions, we're looking at a rhythm that underlying rhythm is regular. The PVC disrupts that rhythm. The rate depends on underlying rhythm. P wave not present with the PVC, right? We don't see it here, so because this is what we're considering, not this. Then we look at the PR interval, it's not measurable. So there is no P, so how can we measure the PR? QRS, wide and bizarre. So those are the words we're looking at when we think of how to identify this. So from here to here, it's very wide and it's weird looking, so it's wide and bizarre, right? So what are the treatments? We're gonna monitor the patient. We'll have warning signs, or ventricular tachycardia, that's our warning sign if it's happened too quickly. Treatment underlying, we're going to treat the underlying cause, and we're going to ask them to change their lifestyles, right? So when we talk about unifocal, right, we're thinking, we said there was ectopic spaces, right, where it can happen. Unifocal means coming from one place. So PVCs arise from the same irritable site, but multifocal arise from irritable sites or multiple ventricular cells, and each contraction looks differently. What could cause this problem? It can be caused by alcohol consumption, caffeine, tobacco, mitral valve prolapse, electrolyte imbalances, okay? And all of these are what threatening underlying causes. If it's severe, it would have 6 or more PVCs, and they would be multifocal, and it will be called a run, so 3+ run, and you will treat it with antiarrhythmics. Okay, so we don't like runs. Here's what a run would eventually cause: a ventricular tachycardia. So again, I mentioned for me, the easier way is to just look at it and know, and memorizing it. So I mentioned, take your slides, make copies, write at the back what it is, flip them back and forth and try to remember. But then again, our last class, or 2 classes ago, we learned how to measure them, okay? So this is what VTAC looks like, commonly called VTAC. where there are 3 PVCs occurring in a row with a rate of 100 beats per minute or higher. So ventricular tachycardia is an extremely unstable rhythm. It can occur in short proximal bursts lasting fewer than 30 seconds and cause few or no symptoms. Alternatively, it can be sustained, requiring immediate treatment to prevent death, even in patients initially able to maintain adequate cardiac output. So when we think about this, we said our biggest problem is the ventricles, right? So with the ventricles, if they're not contracting properly, we can see there's going to be a problem with cardiac output. The extremities are not going to get the blood they need. The organs are not going to get the blood they need. So the person cannot stay in this. If it's a quickie and it comes right out, that's not as bad of a thing. But if it, first of all, keeps happening, it's not good. And if it's sustained or maintained, that's not good. So what are the characteristics? The rhythm, usually regular, right? Makes sense, right? The distances between each of these are regular, okay? So the rate 150 to 250 beats, P wave not identifiable, PR intervals not measurable, right? So we don't see a P wave in between here. We can't find it, so we can't measure PR. QRS wide, greater than 0.12 seconds. Treatment, we're going to assess the patient and we're going to look at whether they have a pulse.